مهفان. مساء الخير عليكم جميعا. اسمحوا لي بأن أقدم نفسي وزميلي. أنا رويدة مقداد وزميلي مهفان جمعة. أود أن أشكر الأستاذ الدكتور أثير والدكتورة علا وجميع أعضاء اللجنة التحكيمية للمؤتمر على إعطائهم فرصة لنا بالمشاركة بهذه المنافسة العلمية، وعلى جهودهم معنا في هذه الأسابيع الماضية. شكراً. موضوعنا اليوم هو عبارة عن مرض شائع وغالباً ما نسمع به، الذي هو النقرس أو بما يسمى داء الملوك. سيكون المحاضرة باللغة الإنجليزية مع بعض الكلمات العربية للتوضيح. So, after this presentation, you will know what's gout, how does it occur, the mechanism behind gout, primary gout, sign and symptom, diagnosis, how can we treat it, and management. Now, Mehvan will clarify to us what is meant by gout.
Okay, thank you so much there, Ruwaida. And I hope sound is clear. Dr. Athir, is sound clear?
ممتاز مهوان.
Okay, thank you so much. So let's begin with our presentation. So gout is a common type of inflammatory arthritis which causes inflammation and intense pain in joints, most commonly affecting the joints of the big toe. It is characterized by hyperuricemia, which is the increased levels of uric acid above normal range. Gout was historically known as the disease of kings or rich man's disease. So what do you mean by that? So because in past, in ancient kings and rich men were eating a lot of meat and foods high in purine content, like and especially beverages like alcohol and so on. So eventually they developed gout, and for that's why it was known as the disease of kings or rich man's disease. Of course, we said hyperuricemia is defined as the serum uric acid concentrations above normal range. Then in men, it's defined when it is 7 and above 7 milligram per deciliter in men, and in women above 6 milligram per deciliters. Of course, the uric acid, like any other substance present in our body, with a normal range, it's useful for our body, especially it acts as an antioxidant. And while when it exceeds the normal range, this is the problem comes to existence. Okay, now, of course, there is a fact behind gout. So, Ruwaida, could you please clarify how does gout occur?
Sure. Firstly, we have two groups of nitrogen bases, purine and pyrimidine, purine, adenine, and guanine. We have two sources of purine, exogenous and endogenous. Exogenous, like that, these figures show it's present in meat, in liver, kidney, beans, peas. In endogenous, we have in our nucleic acid in DNA and RNA. In normal condition, uric acid is present at dissolved salt, but when it reaches high concentration, when there is overproduction or under excretion of uric acid, it will build up in tissue and cause inflammation and pain. So uric acid is the end product of purine. This figure shows cross-section of joint with urate crystal. As we said, gout is hyperuricemia, high level of uric acid in the serum. When uric acid reaches this level in the serum, it will precipitate as it is salt, monosodium urate. It precipitates in joint and its surrounding tissue as crystals. The main site or the classic site of the disposition of the monosodium urate is the joint of big toe, but it also occurs in other joints like the joint of elbow, wrist, knee, etc. This figure shows the mechanism how adenine and guanine convert to uric acid. Adenine and guanine, as we said, it's present in our DNA and RNA. Xanthine oxidase is the enzyme that's present in our body. It converts adenine and guanine to xanthine and hypoxanthine, and then it will convert to uric acid that's responsible for the gout. Pharmaceutical company targeting this enzyme, xanthine oxidase, to inhibit production of uric acid in gouty patient. And we have drugs that act and inhibit this enzyme to inhibit production of more and more uric acid.
Ruwaida, could you please clarify how does the we have another group of drugs and it's actually available like pegloticase. Could you please clarify a little point on how does this occur and how does this mechanism work of this drug?
Yes, pegloticase is acted by another mechanism. We have in animal, we don't have gouts because they have another enzyme called uricase that's responsible of converting uric acid to another soluble compound. But in our body, we don't have uricase. They do a DNA recombinant technology for that enzyme in animal and convert it to drugs that we use it now.
Thank you so much, Ruwaida.
Now, we have two types of gouts, primary and secondary. Mehvan, could you please clarify what we mean by primary and secondary?
Sure. So primary gout actually is associated with hyperuricemia. That's with an essential hyperuricemia. So it has a polygenic basis. And the first one is a metabolic overproduction of purines. And the second one, the decreased renal excretion, increased dietary intake of purines, and inherited defects of enzymes in pathway of purine metabolism, and Lesch-Nyhan syndrome, and finally glucose 6-phosphate deficiency. I will clarify 3 points from them in this pathway. So the first one is in this figure we see that this is the number one synthesis of purines. So in case of glucose 6-phosphate deficiency, deficiency, there is high amount of ribose 5-phosphate, so which is the precursor of the purines involved in the synthesis of purine metabolism. So will lead to high purine content in body and finally hyperuricemia. And another point, let's say, so in case of metabolic overproduction of purines, if we look this enzyme, PRPP amidotransferase, when there is an increased activity of this enzyme, which is also involved in the synthesis of purines. So when there is increased activity of PRPP amidotransferase enzyme, there will be increased production of purines, synthesis of purines, and which will eventually lead to the hyperuricemia. And if we look to HGPRT enzyme, which is involved in the salvage pathway of purines, so HGPRT enzyme, which is hypoxanthine phosphoribosyl transferase enzyme. Of course, this salvage pathway is responsible from recycling of the products resulting from the breakdown of the nucleic acids to be used for the formation of new nucleotides. Then, if this HGPRT enzyme, which is involved in this pathway, is deficient, as in case of the Lesch-Nyhan syndrome, of course, there's no salvage pathway of purines, and which will add to other purine content, and then will lead to high purine content, eventually hyperuricemia. And then we have secondary gout. Secondary gout is associated with the hyperuricemia, which is due to which is not hyperuricemia is not main problem, but it's due to it happens in other conditions and diseases. For example, in case of renal retention of uric acid, as in any case of kidney disease, acute or chronic, we have decreased excretion of uric acid. And as a consequence of administration of drugs, diuretics like furosemide competes with the uric acid for the excretion from the body. So will decrease the excretion of uric acid. And then in organic acidemia, either in diabetic ketoacidosis or lactic acidosis, acetoacetate and lactic acid in this in these conditions decrease the excretion of the of the uric acid, and hence acute hyperuricemia will happen secondarily. Finally, increased nucleic acid turnover. In case of malignant diseases, in let's say malignant disease like cancer, and that's cancer, I mean. So there is a rapid proliferation of tumor cells, and in massive destruction of tumor cells as the patient take chemotherapy. So there's rapid breakdown of the nucleic acid, and we know that purines are present in nucleic acid. So then there will be high purine content, and eventually hyperuricemia. This is known as the tumor lysis syndrome in case of chemotherapy. And signs and symptoms, of course, like any other diseases, it has its own signs and symptoms to be recognized. Now, inflammation, intense pain in affected joints, usually the classical site, which is the victory, and limited range of motion, long-standing elevated uric acid levels, which may result in painless deposits of uric acid crystals known as tophi, which may lead to bone erosion as a complication, and of course, which may also lead to crystals precipitating in kidney, which finally will result in kidney stones and ureate nephropathy. Sometimes we have patients with the gout who are asymptomatic. So the problem with these patients is the follow-up with the asymptomatic patients is most of the time undertaken. And the reason is that they don't develop signs and symptoms of gout and of attacks, then but they are at high risk of developing kidney disease from crystals of uric acid precipitating in kidney. Then diagnosis. Ruwaida, could you please give us some materials we could diagnose it by?
Yes. We can diagnose gout by physical examination and some laboratory tests. By physical examination, we will see the joint is hot, swollen, and painful. In the laboratory, we will determine blood uric acid level, which is maybe above the normal range. Then we can use another test, taking a sample of fluid from affected joint. And it is very important to ensure that there is a high level of uric acid in that joint that have pain and inflammation. Imaging techniques for patients with long-standing gout. Imaging techniques will help us to know if there is any erosion in the bone, and we can see that the crystals that present in the joint. But sometimes uric acid level may be normal, and the patient have gout. It's like the hypertension. Sometimes the patient have hypertension, but its range is normal. So it is the same thing. The uric acid level may be normal, but the patient is gouty because there is no attack, no trauma, no any condition that elicit the inflammatory condition to rise the uric acid. We can treat the gout. Firstly, we have acute attack and we have long-term treatment of gout. What is the difference between acute attack and long-term attack? In acute attack, there is a condition that causes suddenly rise in uric acid. Maybe the patient taking a drug that prevents the excretion of uric acid, or maybe there is a dehydration. In dehydration, the concentration of salt will increase. This elicits the immune system like macrophage, neutrophils, and that macrophage will release cytokines that cause the severe inflammation event. So in acute attack, we just focus on the treating the inflammation, not decreasing the uric acid. This drug called like colchicine, non-steroidal anti-inflammatory drug, oral or parenteral corticosteroid, canakinumab. Long-term treatment, we have xanthine oxidase inhibitor. Xanthine oxidase inhibitor, like I explained before, it's responsible for converting adenine and guanine to uric acid. When we inhibit this enzyme, sure, there will not convert to uric acid and decrease its level. Uricosuric drugs, this increase in excretion of uric acid from the kidney. And we have low dose of colchicine or non-steroidal anti-inflammatory drug with it to decrease the inflammation event.
And I think the use of the low dose colchicine and non-steroidal anti-inflammatory drug is that with long-term treatment of gout, they take time to reduce uric acid level. Then, especially like allopurinol, when it's taken, then it may aggravate the uric acid level and will rise its level somewhat, will lead to attack. So for that's why the low dose colchicine or non-steroidal anti-inflammatory drug is taken as a prophylactic for gout attacks with the long-term management.
How we can manage the gout? By avoiding alcohol, because alcohol decreases excretion of uric acid. Avoid purine-rich vegetable, like foods like spinach, mushroom, dry beans and peas, animal red meat, liver, kidney, and so on. Avoid drinking high in sugar or fructose because it's the source of the production of purine. Low-fat dairy foods may lower uric acid level and help manage gout, and reducing weight to decrease the uric acid level.
This slide actually shows us how does the pain with the gout feels like. It's really painful. The joint is swollen and it's hot, so it's really painful. It actually mimics the situation with gout. This is for those to feel how the pain is. And thank you so much. We really appreciate your listening. We are delightful to have your questions and comments.
احسنتم باثنين في واحد، فمو مشكله الواحد يتسامح بالنسبه للوقت لهم، لانه طالبين وليس طالب واحد.
والله we do apologize if we exceeded our time actually.
أنا مستمتع معاكم. أي سؤال، أي شيء ممكن تلاحظ الشات مهفان ورويدة.
نعم.
كيف نعالج المرض؟
There's just prevention, not treatment at all. We just prevent. We have treatment for acute attack and for chronic attack. Like we said, allopurinol for chronic and some non-steroidal anti-inflammatory drugs and colchicine for acute attack. Just prevention, not treatment at all.
Yeah, we say we have treatment, not cure. Yeah.
Yes.
So please see the chat, Mehvan.
Victor, it's better if you transfer questions to me.
Okay. From Daria, and could you please show us the structure that you made for uric acid by hand that is shown behind you in the video?
Sure. I will be close to the structure till you see it properly. This is actually our work. We did it actually with our presentation. This is the poster. This is our poster, and this is the structure we prepared. Me and my colleague Ruwaida. It represents the structure of uric acid. Actually, it's handmade. And it's like a 3D structure. So I think it's so clear that uric acid structure.
Good. Which fish type cause the gout?
نعم دكتور.
Question from Hiba Shatter, Dr. Hiba Shatter. Which fish type cause the gout?
We have a type of fish which is called sardines. It causes gout because of
قدح
high
البحر.
بالضبط. Because of high purine content.
Just sardine?
بعث قدح البحر وسرطانات البحر أيضا.
الشريمب. Shrimp also or
بيقطع
no?
الصوت دكتور.
Shrimp.
نعم دكتور.
الروبيان shrimp.
لا الساردينز والانشوفيز هو اللي رويدا حكى.
تمام.